So welcome to this oral evidence session for the ARMA MSK Health Inequalities Inquiry. We know that the incidence of MSK conditions is not equal. There are a whole series of inequalities related to age, sex, ethnicity, social and economic deprivation, and a range of other factors. Doing an inquiry on all of those together would have been incredibly complex. So we chose to start with looking in detail at inequalities related to deprivation. We're currently in the evidence gathering phase to produce a report which will be completed at the end of this year and launched at the start of 2024. And the launch will be the start of phase 2 of the project, which is really about getting the message out there and disseminating the recommendations with the aim that they are implemented. I'd like to thank Grunenthal UK Limited for sponsorship of the project, and Pfizer Limited, Novartis Pharmaceuticals UK and Janssen, who have supported this project through charitable grants. The supporters have no say in the way that this project is run. One of the things about people with musculoskeletal conditions is that they will have other conditions as well. So 1 in 8 people in England have 2 or more long-term conditions, one of which is MSK related. Half of people with heart, lung, or mental health conditions also have an MSK condition by the time they reach the age of 65. And in the most deprived areas, people develop these conditions 10 to 15 years younger than in the least deprived areas. So this is extremely relevant to the topic of our inquiry. And it's therefore very important that we consider how people working to address MSK health inequalities can take account of the fact that people will have multiple other long-term conditions. So that's what we want to explore during this session. And today we're going to hear from 2 people who have slightly different perspectives on these issues. So it's a great pleasure to introduce Alf Collins and Jacob Lant. And Alf, could you just briefly introduce yourself and your interest in this subject?
Sue, thanks. It's lovely to be here. I'm Alf Collins. I'm Clinical Director for Personalised Care in NHS England, and my brief covers shared decision-making, support for self-management, personalised care and support planning, social prescribing, health literacy, choice and personal budget. So a broad brief. I'm a doctor by training, and for 25 years I was a community consultant in pain management in Somerset, and for 10 years worked in the Health Foundation on all of its person-centred care programmes. Lovely to be here.
Brilliant, thank you, Alf. And Jacob, would you like to introduce yourself?
Typical, I'm on mute, Sue. Sorry about that. Hi, everyone. I'm Jacob, and I'm Chief Exec at National Voices. If there's anyone watching who is not familiar with National Voices, we are a charity that is a sort of a membership group of 200 other health and social care charities. We very much specialise in tackling health inequalities and making sure that we help focus health and social care policy thinking around those who are having the worst outcomes at the moment. And we also are big supporters and big promoters of co-production as a methodology for ensuring that it's not people locked in a cupboard coming up with ideas on how to fix these problems. It's actually the people with lived experience with the conditions themselves are helping to shape decisions. So that's National Voices. Myself, I'm relatively new to National Voices, but I've been working in the field of patient and public involvement for over a decade and spent a long time working with the Health Watch Network. So hopefully I can bring in a breadth of experience to that, to the conversation as well.
Brilliant, thank you very much. So perhaps we could start by just briefly looking at what are some of the challenges that are faced by people who have more than one long-term condition, and how might deprivation exacerbate those? Jacob, do you want to start with that one?
So, I mean, well, I was looking through the questions beforehand. I very much looked at this about thinking about how people live their lives. So it's not just the sense of you might have more than one health condition, but actually then how does that interface with all the other challenges that you might face, and how it makes it so much more complicated if you have more than one health condition. And just some of the things I was listing down. So, actually, if you've got more than one health condition, you're likely to be on more than one pathway. In the NHS, you might have different consultants and specialists you need to speak with. you might have more interactions going into hospital, just generally from the health sector. So your interaction with the health system is more complicated. And that creates some very practical issues for people who, with MSK conditions, who might be living in pain and might find actually the physicality of accessing all of those services really quite complicated, and makes it a lot more difficult and challenging for that cohort of patients than it might be for other groups. But I also think then there's when you think about that through a deprivation lens, actually you start layering on some of the complexities around travel costs to get to appointments, to engage with all those different health and care professionals, the time that you might have to take off work to attend all those different medical appointments, and then so that's a kind of, there's a cost of living element to this, that actually having those multiple conditions a problem. And we know that the demographic we're talking about here is going to be a demographic of people who tend to be younger with multiple conditions. They tend to be people between sort of 45, 65, that sort of age range. They're coping with all of these complexities. They are still going to be working. They're going to manage all their health conditions and all of the costs associated with accessing care. They might also be on waiting lists for NHS care and have to take time off work from sick. And actually statutory sick pay at the moment is not keeping pace with the length of waiting times that people are experiencing waiting for treatment. So all of these different things are playing on people's lives and the complexity of managing the condition. And that's before you even get into the clinical side of what medication they might be taking, seeing making all the different points they have to go to. So I very much approach that question of we need to be thinking about actually what's going on in people's lives beyond just their health needs, that makes us really understand the complexity and how it interplays with deprivation.
Brilliant, thanks, Jacob. Alf, did you have anything you wanted to add to that?
Yeah, I think what I have to say is very aligned to Jacob's thinking. I guess the word burden comes to mind for me here. So there's what people in the past used to call burden of disease. Living with long-term conditions is burdensome. It has a psychosocial impact. There is an impact on us as individuals and our core identity, and we have to actually do psychological work ourselves to adapt to changing circumstances. There's a social psychologist called Mike Berry many years ago who talked about so-called biographical disruption. So there's that huge shift in who we are that we have to do work on, in terms of just managing the psychosocial impact of conditions, especially painful conditions. But of course, that burden, that impact multiplies the more conditions we have. And added to that burden is, just as Jacob spoke about, is the burden of treatment. So the burden of attending frequent appointments. Often those appointments, you're told different things. You might be told sometimes contradictory things by different people who are perhaps not coordinating their work with you as well as they might. I think added to that, the deprivation angle means that, just in terms of Maslow's hierarchy, many people have not got bandwidth to do anything other than put food on the table and, keep the house relatively warm over the winter. So what we ask of them, they just may not have the bandwidth to be able to deliver it for themselves, because they're attending to far more urgent and important issues to do with the basic necessities of living. So I think what Jacob and I have said is highly complementary.
Great, thanks very much. And actually, we've had some evidence recently from someone who's working with people who that bandwidth question is really important, with quite significant MSK conditions, who are simply not coming forward for treatment because they don't have the bandwidth to even think about that. So that's quite important. So following on from that, what do MSK healthcare professionals need to bear in mind about their patients who have other long-term conditions, and particularly in relation to health inequalities? Alf, I don't know if you want to start with that one.
So I guess leading off from the treatment burden question, I think having at the forefront of our minds as healthcare professionals is the conversation we're having, and are the potential signposting opportunities available that we might talk, are they adding to treatment burden for this person? Are they making their lives more complicated, more complex? Are they adding to the fragmentation of services? Particularly people living with multiple conditions, they could end up running around seeing multiple healthcare professionals to deal with the various aspects of their lives. So there is something about having in the front of our minds, what is this person already doing or being asked to do by other members of other teams, in addition to what I might be asking of them myself? Not just having it at the front of our minds, inviting people to tell us about what they're already doing, not just in terms of managing their musculoskeletal conditions, what they're doing in terms of managing their other conditions as well. And I think it's really important actually to hold in mind mental health conditions here. Yeah, there's some thoughts.
Yes, and mental health conditions are a very common comorbidity with MSK conditions. Jacob, what would your perspective on this one be?
I was going to pick up on that mental health point actually to start with, because I think you're absolutely right, Sue and Alf, that it's a very common sort of dual challenge that people are facing. Living in pain because of your musculoskeletal condition is bound to take a toll on your mental health, whether that's a diagnosed mental health condition or just generally it's going to be like a challenge for you to face. And actually just even I think some of them, just the mental challenge of having to get up and make your way to that appointment, actually being really aware of what it's taken for the patient to get there, depending on the severity of the condition, that could be really quite a challenging thing. And as Alf said, being aware of like all of the different competing pressures that are put on people, it's not uncommon, and I've heard this in my time at Healthwatch and what I hear through National Voices members, is that people being called to the hospital for 3 different appointments for 3 different conditions on 3 consecutive days, and actually really, and often, like, I do understand the pressure that systems and professionals are under in trying to manage all the competing pressures on them, but it's really, really important that we understand what we're asking patients to do, and the amount of time that they are taking to manage their interactions with the service. If we don't, I mean, because an example of that is you could get all of the different pathways working together, saying, we know it's really difficult for patient Y to come into the hospital. Let's try and coordinate all of the appointments around them, make it as easy as possible, make sure we're giving them all the information they need at this time. Helps with things like prescribing new medications. Actually, you can then get the professionals around them talking about what's the interplay of these different medications we're giving for these different conditions, and what are the different side effects that they might be having, and how do we make a trade-off of those side effects against how the person who's living their life, if they're living in constant pain and you replace that pain with incredible nausea because of another medication that they're on, actually how are you managing that combination? So you're really getting the professionals to think who else is involved in this patient's care is critical. Sometimes the patient you should be asking that question and give the patient the space to talk about that. Other times there's a massive expectation from the patient's point of view. The professional already knows that, like, I'm seeing you about your MSK condition, but actually I am aware that Dr. so-and-so or the consultant over there is seeing you for this other thing, and the professionals don't know. So actually creating systems behind that to help the professional know what other interactions you're having at any one time is really, really important. So the patient shouldn't always have to be the one retelling their story every single time. That's really important for the sense that the system understands you as a user, what your needs are, and is really thinking about you holistically. You can do some of that behind the scenes as well. So yeah, I think that is all part and parcel about thinking about the whole person.
So could I just come back just to add, while we've been talking, I think quite a lot about mental health conditions. So yeah, looking back to my own professional practice, we used to use mental health screening tools for everyone who came into my practice. And why would you not? If you're living with a painful musculoskeletal condition, why would you not feel anxious or depressed or both? It is normal to have degrees of anxiety or depression. I think it's really important that we're aware of the degree to which the anxiety or depression is impacting upon people's ability to cope with their musculoskeletal condition. But to bring it into the conversation, the easy thing to do is to just say, you're anxious, you're depressed, we need you to see IAPT. A more difficult, or I think I would say perhaps the best thing to do is to say, it seems to me that you're feeling quite anxious. That's not unusual. Many people I see are quite anxious. We could think about you seeing another professional. On the other hand, if we can work together to support you to manage your pain and your condition more effectively, it may be that those levels of anxiety naturally decrease anyway. Let's figure that through together, shall we? I think it's just so important to acknowledge that people live with, most of the time, mental health conditions to one degree or another, but not necessarily just knee-jerk refer to the mental health service.
And just building on that, if I may, I mean, I think is building that thinking into the service planning so that the professional feels they've got the time to have that conversation. It might feel like there's a pressure then on the MSK service that you think, oh, I could shunt some of that to mental health or IAPT or something, but actually it's not. It's the collective systems thinking the best way of supporting this person with their needs is for me to sit and have this conversation with you right now. And in order to give professionals that space, we need to factor that into the commissioning. It has to be understood from that base level that actually, if you've not factored in that all mental health problems and challenges may come alongside MSK conditions at your commissioning stage, you've failed at that first hurdle.
Yes, and I think that's true. But the other thing that we hear from professionals is there is a fear around raising mental health questions of not knowing how to deal with the response. So, Alf, I don't know if you've got any thoughts from a healthcare professional point of view about what do professionals need to be able to feel confident to have that conversation you were talking about?
So it's having the infrastructure around you, really, just as Jacob has said. It may well be access to a local IAPT service. It may well be having access to health coaches, care coordinators, social prescribing link workers. So knowing about both the statutory and non-statutory services that are available, the infrastructure around you. And actually a lot of that comes from closer relationships with social prescribing link workers, because it's their job to know about the local infrastructure. I have to say, I worked in a pain management service in Frome it's a very well-known kind of thriving social prescribing link worker service there, and pretty much everybody I saw in Frome ended up seeing the social prescribing link worker and other services as a result. So it's about infrastructure, but it's statutory and non-statutory infrastructure.
I think there could also be a role for a version of advice and guidance that goes from secondary care services to, so primary care can access advice and guidance for a whole range of different things in secondary care. So maybe if you had MSK services being able to call off the expertise of a mental health professional that's there, that doesn't have to be the full referral process. You don't have to send. You just need that little bit of professional advice on how you might take forward a particular patient's concerns. Thinking a bit flexibly about how we're using that resource, I think, was also quite helpful, because this is a team sport, health and social care. We're all in this together. So let's kind of facilitate the mechanisms to allow those conversations to happen.
And that's an interesting suggestion in relation to mental health, but I wonder if you think that would be useful kind of secondary care to secondary care, where someone is seeing a number of different specialties, that ability to get that quick check. I think specialties.
I think absolutely. I mean, one of the key problems that we identify at the moment is that is the bouncing back between secondary care and primary care, and in a sort of an unwillingness at times, because of the pressure on services, secondary care unwilling to talk to each other. And I think also traditionally, like say before the pandemic, a lot of the advice was send it back to the GP, because the GP is acting as the sensible care coordinator in all of this sort of stuff. But there's so much pressure on primary care right now that actually they don't have the time to do that. So we need to, although the guidance might say the best thing to do is to send it back to the GP, in reality, the best thing to do is create a mechanism where secondary care can talk to secondary care. And sometimes that's in the same hospital, sometimes that's in the same trust. Sometimes that's in the same ICS, sometimes it won't be. But I think we need to think more flexibly about those mechanisms of how we can get them to talk to each other, rather than bouncing patients back to primary care, where you might end up waiting a lot longer to get an answer. And it's not really satisfying for anyone. It's not satisfying for the professional who's asking the question. It's not very satisfying for the professional who's answering the question, or for the patient who's stuck in the middle.
If I could just come back in again, so there's
Sure.
something for me about MDTs, integrated neighbourhood teams, MSK hubs. These are all, these terms are being used flexibly at the moment, but there is something, I think, about, you know, having a team close to you in your neighbourhood that has got essentially a multidisciplinary function. It almost doesn't matter what they're called. They've got a multidisciplinary function with really good information flows between them. That's what we're aiming for, isn't it? Again, doesn't matter what they're called, to be quite honest.
Yes, indeed. And we're sort of moving into the next bit that I wanted to explore, which is about services. So in terms of musculoskeletal services, what do they need to think about in the way that they organise in relation to the fact that a significant number of the people they're seeing will also have other long-term conditions? Jacob, have you got any thoughts from a service level perspective?
I think the thing I would be thinking out from a service planning perspective is how I can offer greater sense of continuity of care and continuity of carer. When you've got people, we know that people who've got more complex range of conditions and have more complex personal circumstances, that they are the groups of people who do better with continuity of care, even if it means you have to, you know, it's more of a struggle to schedule the appointments. Actually, there's a really important part of that continuity of carer. It plays a really important part in improving health outcomes. And also it's because that person can hold on to other bits of information about you that the system doesn't hold. So it's all that sort of social kind of information about you, your working status, your housing situation, all that sort of stuff that would not be included in your patient record, but actually if the professional knows you a bit, they hold on to that more. So I'll be thinking really about how I can enhance continuity of care. I also so that would be the first thing, but I also think about that in, you know, it's very difficult to always have the same care professional seeing a patient, and just in the realities of how the current health system is set up and the pressures on it. So how can you give a sense of continuity through digital systems that you put in place, so that if a patient is in front of a new clinician, a new professional at a point in time, how do I make sure that that person understands as much as they possibly can about the person's wider context and how they live their lives and the other pressures on them? Again, it can help build that sense that the NHS cares about you as an individual, not just your condition, and it doesn't really matter who you see. So it's think about continuity as continuity of carer, but also that informational continuity, I think, is really important. So yeah, that would be my first priority. I think I'd be thinking about.
Thank you. Alf, did you have anything to add there?
I completely agree on that. And I guess we've touched on this already. Continuity, coordination. And by coordination, I think I also mean rationalization. You know, what we don't want is to add to treatment burden, is to further fragment care and support for people. There's some great work in the States on a NAIC called Patient Priorities Care, where essentially it's a highly personalised conversation. It's probably a personalised care and support planning conversation with people living with multiple conditions, bringing all the information into one place, bringing all the information into one plan, but actually taking it according to the individual patient's priorities, one step at a time. You know, what we tend to do when we do personalised care and support planning is offer 5, 10, 15 different things to patients. Patient Priorities Care says, let's take this one at a time according to the priorities of the individual patient sitting in front of you. So there's some thoughts.
I think now it's building on that. I think that asking the patients what they want to achieve, you know, what is the purpose of the care that we're delivering? Is the purpose of the care to manage the pain? Is the purpose of the care to support you to continue to work? Or is it to achieve a particular, you know, thing you want to do in your life, you know, the thing that is important for your mental well-being, you can't do that anymore because of your MSK condition. Actually, really making it very tangible. It's like, ask the patient what is their objective. I think that would also help. I mean, it's difficult because then you're shifting your sense of what your outcomes are and what you're measuring as success as a service. We often tend to measure success in a service as number of outputs and whether we've met a particular time frame for a target. And actually, if you shift your focus to outcomes that are driven by the patient defining what they want to achieve at the end result of their treatment, that's a brave thing for the system to do, but actually it's far more meaningful and making sure we're focusing on what the individual wants and needs.
Just build on that. Completely agree. Problem is we're going to vigorously agree with each other, aren't we? Completely agree. I guess in terms of goals-driven approaches, there's some really interesting work from Glyn Elwyn in the States. Often when patients see clinicians, I use the word patients advisedly here, just in terms of distinguishing between roles in conversations. Patients often come wanting to please professionals, and they talk about clinical goals. Not always, but often. You know, we really want to shift them into kind of meaningful goals for them, kind of values-driven goals. So it is something I think about being trained in these ways of working, kind of the what matters to me conversation, and moving it away from clinical or even, dare I say, activity-driven goals towards values-driven goals. You know, the kind of person I want to be reasonably. So I think there's a piece there. And of course, to be able to measure the impact of that, you've got to use PROMs. And I think we need to move towards using PROMs much more. But that's a bit of a bugbear of mine. I don't want to get hung up on that.
So I'll join you on the streets with the placards, Alf, on that one. So
just following on from that, Alf, you mentioned training. Do you think training does deliver the sort of behaviour change by clinicians that we're really looking for here, and what else can be done to kind of bolster the chances that that training will make a difference, make the difference that we're looking for?
Right. So there's a number of different facets to this. So we've set up the so-called Personalised Care Institute. For people who are not aware of it, it is a training hub for ways of working with people that kind of addresses the kind of what matters to you challenge. We've got avatars there that are really cool, really cool. And first time I used an avatar, I've been a trainer in communication skills for 30 years. I learned something. So you know, there's some good stuff on the Personalised Care Institute website. There are, of course, in multidisciplinary teams in primary care now, people who are either dedicated health coaches or trained in health coaching. And of course, we have care coordinators and social prescribing link workers. So I think, yes, there's a need for training, but I think there's also a need for us to step back and think, actually, this ways of working is a team business now, albeit there's the continuity of care piece that we need to factor in. So this is complex, but there are people in neighbourhood teams now who are trained in health coaching. What I would say is, in terms of the kind of mindset shift, the shift towards from being a fixer to becoming a facilitator, the evidence that e-learning can do that at the moment, to kind of really dive into detail of your question, is as yet relatively unexplored. Face-to-face training does make a difference, albeit that it's highly, it takes a lot of time and it's very costly.
Brilliant, thank you.
can I come in on the training?
Something? Yeah, please.
Yes.
Do.
So I think it's less about specifically at the kind of the education, like the first level training for health and social care professionals. Like, that's not really my area of expertise. Where I do see kind of if we need to do more training and development for senior leaders in the understanding of why it matters to listen to patients about the outcomes that they want and why you need to have that way of thinking. You do have some people at senior levels, I mean, Alf being a case in point of people who've championed this for a long time, but there's still an awful lot of senior managers who have got, they're thinking about the financial pressure and the fact that, you know, the constitutional target pressures and stuff put on them before they're thinking about the user outcomes. And so I think we need to think about ways that we build more opportunities for senior leaders to understand what sort of shared decision making, what co-production, what it actually means, what it looks like, how to do it authentically, understand that it's not scary, understand it's actually more about a point. It's not going to cost you more, it's not going to take you more time, it's just about where you invest your time and how you set up the power dynamics of conversations. I'm not going to say doing valuing co-production and shared decision making is going to save you money, but I don't think it costs any more. I think it just changes the balance of how you're doing things. And yet, so we need senior leaders be given the breathing space to understand that. And we need to help them. And there's partners in the statutory side and in the VCSE sector who will be able to help with that. I mean, National Voices does its own sort of Voices for Improvement training program where we kind of upskill senior leaders in understanding lived experience and co-production. And I think the more that we give space for that, the more then you'll get senior leaders saying, oh, well, our education needs to be, I wish I'd learned this in my earlier stages of my career. I wish I'd learned this before I graduated from medicine. That's a really important part of how we can actually move this forward, not just thinking training in its most base sense. It's about throughout the entire career and how we support that.
Brilliant, thank you. That's really helpful. And Jacob, I wanted to briefly go back to one thing you mentioned as well, which was the thing about what's in the patient's records and what's in the clinician's head, because one of the things that we're hearing from some of the clinicians who've given evidence is some of them have a really good understanding of their patch, where the areas of deprivation are, which are the patients that might be coming from a more challenging background. But some of them are saying, I just don't know. When I see someone, I haven't even got a clue whether this is someone from one of the more wealthy part of my patch or the people in areas of deprivation. That's even more challenging when you're talking about some of the specialist, for instance, rheumatology services for children and young people who cover an enormous patch and can't possibly know it inside out, back to front. Have you got any thoughts on, where's that balance between what you put in the record so that it can be shared and stored, and what is more just a conversation between the healthcare professional and the individual?
I think it's about prompts for things. So and you can often get stuck in spirals of no one really feels like they've got the power to change anything that's in the records. But if you could just design it from scratch, I mean, if I just had freedom just to design it, in a patient record, I might want all of the stuff that the patient's told me, and I'd want to see what the patient's told all the other clinical professionals they dealt with in that journey. I'd want to know which bits of records have happened most recently and most relevant to the condition that I'm treating clinically in front of me, and then other bits of information which are are the important contextual information that a patient could update over time. So a patient go in and say they can update what their if there's a family member who's helping care for them, for example, or if they've got caring responsibilities for a family member, they could update their language preferences and needs and things. And if you say you're being affected by gradual hearing loss, actually, is there additional support you need? So there's all these different things that you could change about your contextual needs in the patient record. And then you've got the advantage of what is AI doing and drawing from data sets that exist. So at that point, if I don't know whether this patient lives in a patch of deprivation or not, that would be relatively straightforward to have the indices of multiple deprivation mapped against postcode on the patient record and a little red flag that says this person lives in an area where there's got high levels of deprivation. You might want to consider that in the consultation. Now, it doesn't necessarily mean that they are cells from a deprived household, so you'd have to worry about what assumptions that you're making, but it's a prompt for the conversation. Likewise, you you might have an area that is really not affected by deprivation at all, but we know within that there can be pockets, so you can't lean on it too much, but actually at the same time there can be some prompts that will probably help in a lot of circumstances. And that's not where you're using AI or sort of data processing is probably better than a term than AI. You're not using it to make a diagnosis, you're not using it to make judgments, but you're using it as a prompt to help clinicians manage a wealth of information they'd never have time to sit down and Google themselves. And it can help just skip over a few things because you're still going to be pressured for time in that consultation, so you're not going to be able to take an entire life history every time. It can just help you skip through some of those things.
Thank you. Alf, I don't know if you have anything to add to that.
Yeah, just I suppose I'm going to come at this slightly tangentially, actually, and so I guess for me there's something important about the impact of deprivation on the individual, and so there's there are certainly simple questions that we can ask in a consultation without using a formal self-efficacy tool or activation or health literacy tool. So tell me what you're already doing to manage your health. What ideas have you had? What thoughts have you had? Have you spoken with other people about your conditions and what they do? So simple prompts like that. The other piece that comes to mind is actually using maybe an MSK prom, and or for people living with multimorbidity, a more generic prompt. So there's something called the LTCQ that Oxford and Kent and LSE developed a few years ago. It's a 20-item questionnaire and mapping progress for people as they see the various members of the multidisciplinary team as to whether the team is actually supporting them to make improvements on their prompts. I've come at it slightly tangentially there, so I hope it's helpful.
Yes, very helpful. Thank you very much. So I just want to take this a step up now and think about the health system. So in England, that would be the ICBs, ICSs equivalents in the other nations. What do they need to be thinking about in relation to MSK, the importance of MSK in terms of their population, but the fact that substantial number of those people with MSK conditions also have other long-term conditions? What might the systems need to be thinking about? Alf, I don't know if you want to start with this one.
So this might sound like heresy. I think you need to start with multimorbidity rather than MSK. If we're talking about MSK in the context of multimorbidity, start with the challenge of multimorbidity. And what that means in terms of the way we organise our system at national and ICB level. There is going to be far much more attention paid to the problem of multimorbidity and the relationship with deprivation, I'm sure over the next year or two. So multimorbidity first, what that means in terms of the constitution of your system and the skills required. And I think this is where MSK comes in, because we know that MSK conditions are highly impactful, highly burdensome, and will make a greater contribution to the burden of disease, if I might use that term, than many other long-term conditions by their very nature. So I would put MSK conditions and mental health conditions, kind of sit them there neatly, right as the second kind of rung under the multimorbidity umbrella, alongside other conditions that we currently have as second rung: diabetes, CVD, and respiratory conditions. I do think MSK conditions have got an almost unique impact on people's quality of life, because they're often associated with mental health conditions, and pain is just not a very nice thing to live with. There's some thoughts.
Thank you. And the other impact, of course, that MSK conditions have, the versus arthritis report into multimorbidity a few years back found that for people with long-term conditions, it's often the development of an MSK condition is the tipping point between managing quite well and really struggling to manage your other conditions. So they definitely interrelate in all sorts of ways that makes MSK important. But yes, take your point about start with the multimorbidity bit rather than start with the MSK. Jacob, what would you add to that?
So I'm not sure it's whether something I'm
thinking on it yet, but I would say that one of the things that narratives I'm noticing is the rise in importance and recognition of the importance of MSK conditions because of the a sort of a flip that we've had in
politics and policy thinking is we used to talk about we need a strong economy to have a strong NHS. And now we're talking about we need to have a strong NHS or a strong healthy nation to have a strong economy. And the MSK is therefore sort of as one of the biggest contributors, like as conditions who've forced people out of the workforce. There's something about riding that wave in system thinking about, you know, how are systems making sure that we are supporting people to live as pain-free as possible, to be as healthy as possible, so they can have fulfilling lives, of which work often plays a massive part of that. It also is a big interplay with mental health. If people have, you know, feel like they're doing something and they're contributing and they're not and they're sort of more economically stable, can have a really important impact on their mental health. So I'm not sure how much I buy into the idea that that we need that healthy people to have a healthy economy, and is that I would rather think about it if we should have healthy people because we should have healthy people and support them to live good lives. But given that that's a sort of a zeitgeisty thing at the moment, it's probably not an unhelpful thing to be button to push with systems of saying this is, you know, this can help you focus on MSK and why MSK is so important to look at. So that's a slightly counter to what Alf was saying, but I kind of agree that Alf, the system will probably look at comorbidity first, but actually, you know, we have an opportunity to ride that wave and raise the profile of MSK conditions.
And I think that's the points you make about the national profile going up. So in England, we have the major condition strategy, 6 major conditions, MSK is one of them, a lot of focus on interrelationship, multimorbidity, prevention, all of that. It is definitely driven by the needs of the economy from a political perspective. Now, one of our concerns is that the MSK aspect of that will not filter down to the system level. But I think that there's also the risk that the bit about multimorbidity and joining things up won't filter down to the system level. It's very much a government agenda, not a system agenda, not an NHS agenda. And at the moment, it feels like in most places, it is very siloed. Have our MSK services and our diabetes services and our mental health services. And as you say, often you have to refer back to primary care to get referrals in. So I wonder if you've got any thoughts on how we might, what are the issues around getting the systems to think in this way now that we have government making it a higher priority?
It's interesting. I think that you talk about the major condition strategy, and I think it's obviously as a membership body representing a lot of different conditions and communities, there's kind of a real varied viewpoint on support for the major condition strategy, because some conditions they've lost their own independent strategies in that, and they're, you know, there's questions about that. Others are being recognized in a way that they haven't before. The big opportunity to hold on to from is to have that cross thinking about different conditions, think about comorbidities, think about integration, think about the metrics of how we judge performance of helping people achieve what they want to with their lives, and supporting as much as we can. And that is the thing, I think, that from conversations I've had with different political parties and people, that wherever you sit on the political fence, they've got that. So I think that's a concept that's here to stay beyond the general election, whether whoever ended up winning a general election. I think that concept of we need to think of that, the cross-cutting issues. And then I think as a comeback to the performance measures, I think you can force systems to think about this if you think about the performance measures from the outcomes and the PROMs perspective. So if we could push that more through the major condition strategy, I think you will see MSK sit in more of a priority at a system level, because it's filtered through. Politically, we decided it's a priority, so we've put it in what we judge success for the NHS. And I very much I wish it wasn't so, but I have seen in my time in the NHS that what we measure is what gets done. So actually, if we can change the measurement, then you can change what gets done at national or system level.
Yes, one of my personal views is that the number one measure at every level should be healthy life expectancy. What direction is it going? But that's a different thing.
Absolutely healthy. I mean, the ambition to just increase life expectancy and to close the gap around health inequalities is important, but it's not that important if we're extending lives and people are just living in pain and not fulfilling what they want to. So they do have to go hand in hand, but we've simplified it. Government has simplified it to let's just make people, we're not seeing a dip in life expectancy regardless of what outcomes you're actually achieving with those years that you have in later life.
Thank you. Alf, did you want to come in again at all?
And my response, I wrote down here healthy life expectancy. That was going to be my response. Yeah, you know, we know, don't we, that the greatest contributors to healthy or the greatest eroders of healthy life expectancy are mental health conditions and MSK conditions. So, you know, if we can keep pushing government and the next government to think more about healthy life expectancy, they're always going to tie it to the productivity agenda. That's just a fact. But nevertheless, if we can keep pushing the healthy life expectancy conversation, then MSK and mental health sit very, very neatly there, right underneath it or right alongside it.
Brilliant, thank you. So just before we wrap up this session, which has been incredibly valuable, I just would like to ask what you think is, well, I always hate those questions, oh, what's the one most important? So what are the one or more most important messages that you would like us to include in our report on this issue of multimorbidity? Jacob, do you want to go first?
So I think I'll probably pick on that the point last question. Like, focus on what we're measuring, get government to focus on the measures in the NHS about what matters most to users. So healthy life expectancy being a good example. And I think if we do that, then we move the conversation. But we could even build those sorts of measures into a new version of the NHS Constitution, for example. So the NHS Constitution's got to be updated by 2025. So there's an opportunity to think about that. There's a lot of talk in the system about what is the contract between people in the NHS, or the social compact, or whatever phrase you want to use to describe it. Actually, that also opens up conversation about that measurement of success. Let's get it focused on what matters most to patients, support people to live the lives that they want to lead, and hopefully we can then get all the other policy bits to fit in behind that. You know, that's the impetus that will kick the system in the right direction, and we could do all the bit of getting people to follow that through.
Brilliant, thank you. And Alf, what would be the things you think are most important for us to include?
Yeah, are we adding value to people's lives? The only way we're going to know that is by using PROMs. Recognise treatment burden and whether you're adding to burden rather than adding value. Ensure that you don't further fragment care. And I'd add one thing which we haven't actually touched on, but I think it's so important. Of course, supporting people to become more active is core to the whole multimorbidity agenda, including the MSK agenda. But it doesn't necessarily mean forcing people to go down the gym or making parkrun more attractive. What we talk about in the MSK field, of course, is meaningful activity, which might be popping down the shops. It might be going around your garden once or twice a week. But that, again, it sits very, very closely with the personalised care agenda. It's what matters to people, and what matters to them may well not be going down the gym. Certainly wouldn't for me.
Brilliant. Thank you both very much. That was really helpful. And I think will add a lot of value to what we have, the evidence we've got for our report. So thank you both very much.